Assalamu alaikum. Today the case for presentation and discussion is the left adrenalectomy. The patient here is a 28 years old male who is having hypertension and is having palpitation and a few episodes of syncope. And he is also an insulin dependent, having insulin dependent diabetes mellitus. And upon general symptoms, when an ultrasound was performed somewhere in periphery, it turned out to be having an adrenal mass. So we are performing left-sided adrenalectomy, laparoscopic of course, and the steps are the same as for other procedures on the left side. So we mobilize the colon medially, and then we identify the ureter, and then we identify the gonadal vein. Here you can see that the ureter has been identified by its peristalsis, and this seems to be the gonadal vein, but there is another vein going parallel to it, which may be a mesenteric vein. To clarify the picture, so we follow this gonadal vein from the internal ring towards the kidney and the renal hilum. And the purpose of this is is that the gonadal vein usually leads you towards the renal hilum and the renal vein. And once you identify the renal vein, then you dissect the adrenal vein, and then you clip the adrenal vein, and then you proceed with adrenalectomy. This here you can see the upper pole of the kidney and the groove between the upper pole of the kidney and the adrenal gland. So slowly and gradually we are moving towards the hilum of the kidney and the renal vein, and you can see that the mass is so aggressive that it is causing a lot of edema around the renal hilum, and there are so many new thin-walled vessels, which is neovascularization, and then the renal vein is having a lot of edema around it. So a slight bit of mistake can lead to a lot of bleed. The patient here is of small stature and having a very small abdomen, which accommodated around 3 liters of carbon dioxide. And I usually perform my procedures in such cases at a pressure of around 10. So we'll see later in the process. It is really difficult to perform procedures in smaller abdomen because you have very small space, and especially in the males, the abdominal wall is not distendable, so you have very small room to move around. The maneuverability is usually limited. So after seeing that there is edema around the renal vein, there are neovascularization, there may be some bleeding around the renal vein. So I decided to go against the principles, and I started to dissect the upper pole of the kidney from the adrenal gland, so that when by the end of the procedure I'm going to clip the adrenal vein, then there is going to be a lot of congestion in the neovascularization, which may lead to rupture of these veins, or at least a lot of ooze from the gland. So that when I clip the vein, I have mobilized all the glands so that it can be dealt with quickly. Here you can see the field is becoming red already, so I have to move quickly. So the pressure that I'm keeping here is 10, just because of the smaller abdomen. I don't want to have any complications of increased intra-abdominal pressure. And then during the process we'll see if there is a bleed and if there is ooze from the gland and from the edematous tissue. Here you can see another angry looking vein which is entering the renal vein. So this is the second adrenal vein which is draining into the renal vein. And it is thin-walled as well, so clipping it is going to be a problem. Here you can see that ooze has already started. So during the process, if we feel that there is a lot of bleed or ooze, we may increase the pressure maybe up to 14 or 15 at the max. I'm not going to increase it to 18, and that is going to be for a really short period of time. So here you can see this, at this step, we were about to injure the artery or the branch of the artery which is supplying the upper pole of the kidney. So usually one adrenal artery is originating from the branch of the artery to the upper pole of the kidney. That has to be kept in mind. So while dissecting the gland away from the upper pole of the kidney, you must keep in mind the artery to the upper pole, so that it is spared and not injured, because if this artery is injured, it may be supplying a significant portion of the kidney, and that will be lost in ischemic. So here you can see that there is a small artery which is arising from this branch of the renal artery, but it is accompanied by another thin-walled vein. So it is not easy to dissect this away. However, we are trying our best to create a plane between the two vessels, and then we also try to dissect that second adrenal vein which is draining into the renal vein. So it is all oozy all around, so dissection has to be quick. So after doing a minimum dissection, I'm not really happy with the completion of the dissection of these vessels, but I have to move swiftly in order to get this gland in control. So here this vein is clipped and it has started bleeding, just because that after clipping of these two veins, there is a lot of congestion in the gland, and there is a lot of distension of the veins over the adrenal gland. You can see around the clip that the vein is getting more and more engorged, and this leads to increased pressure in the gland, which can dislodge this clamp very easily. So I'm struggling with the bleeding, but still the pressure is low. So this portion is separated and the artery is preserved. Then the second vein is being cut slowly and gradually, bit by bit. But now you will see that after cutting it, since the vein was so big that we could not completely cover it, so I'm using the ligashore, and you can already see the engorgement of the veins over the gland, and this can lead to dislodgement of the clip because of the pressure, or because of the manipulation of the gland. The clip may dislodge and it will start bleeding. So what we have done is that still the pressure is low, as there is no significant bleed, but we have informed the anesthetist that he should be having blood at hand, because we may encounter some bleeding. So while we were performing this procedure, me and my team, we discussed that let's start the procedure laparoscopically, and then during the procedure we will decide whether we should continue laparoscopically or convert it. So we are proceeding slowly and gradually, and the gland is oozing a lot, and now my aim here is to control the main renal vein, because it is so big, and we are almost done with the dissection of the here you can see that the clip is dislodged and the engorged vessels are bleeding like anything, and they are so thin-walled that the more I coagulate them, the more it bleeds. However, in the meanwhile, I don't know about the patient's adrenals, but our adrenaline is at peak as well. So you can see that there is a lot of ooze as I'm dissecting away the adrenal gland from the kidney without any coagulation, because using a monopolar seizure or a bipolar or even a ligation may lead to an inadvertent injury to the main renal artery. So at the cost of this small ooze, I'm trying to save the main renal artery. And when I'm sure that we are in a space away from the main renal hilum, then I'm using the ligation. But here, after dissecting this, we have found that there is another artery. So in the continuous oozing environment, I have decided to separate this main adrenal vein from the renal vein and try to clip it and then cut it so that I can quickly mobilize the adrenal gland without injuring the renal vein. So what we are doing is that I'm having suction in my left hand. Mind you, this part of the adrenal vein is so edematous and is so adherent to the structures around it that it's really difficult to dissect. So both of my instruments are now touching each other, and I can feel the tip of my right angle forceps, and then I apply a clip. Although I apply it blindly, however, we are lucky that it is safe. And now the patient's blood pressure has started dropping. So we have started with the fluid, and we have started with the hemocil, and we have also started with started with the blood transfusion. And here again, you saw that there was opening of another thin-walled vein. So aorta has to be kept in mind at this point. So trying to dissect it away from the midline and towards the gland, and having suction in my left hand and having a dissector in my right hand. So now we are trying to apply another clip. A surgical gauze piece here and there, and a surgical helps us reducing the bleeding and cleaning the field around. However, it is a continuous struggle, but we are not converting. We have not yet decided to convert, as everything is safe. So again, dissecting around that portion so that another clip is applied towards the gland, and then we'll be cutting it. Here I'm touching the forceps again, and now we have applied another clip, and now we are cutting. I tried to apply the third clip, but it was not possible, so we left it there. So the renal vein has been detached from the adrenal vein. Now the things are a little in our favor. At least we are not fearing the injury to the renal hilum or the main vessels. So now we have increased the pressure to 14. Here you can see that again that engorged vein is opened. So now we are dissecting, and in this tissue I found that there is another renal artery which is supplying the adrenal gland. So that artery needs to be separated. So actually we are mobilizing the adrenal gland from the midline structures, as it is important to remove. It is important that what structures you are removing, but it's more important that which structures you are leaving behind. So here you can see that there is another artery, a small artery, which is coming to the adrenal gland. So we clip that artery also, and then we cut it. So now every structure that is coming in our way, and that structure is cord-like, I am trying to clip that and then cut it. So after a struggle of around 1 hour with the bleeding and the clots, we are able to control the situation. Although 2 pints of blood have been transfused to the patient. There you can see another artery which is coming from the most probably aorta. So that has been clipped as well. And now I have to keep in mind the spleen, because dissecting it from this side may lead to splenic vessel injury. So I have to rotate the gland laterally to see where the spleen is. And then we will deal with this as well. So the spleen has been now dissected away, and the splenic vessels are not in danger. So here what we are going to do is that there is a cord-like structure coming to the adrenal gland. So we are going to clip this structure as well. The first clip was not able to be applied properly, and now here you can see that the gland has been detached completely. So the adrenalectomy is completed. Post-operatively, so here you can see that we are applying Surgicel, the Spongeston, and some more Surgicel. After washing the area thoroughly and suctioning it, and then seeing no major vessel was opened, there was no major bleeding. So a lot of small bleeding spots, they have been coagulated with bipolar, and then we will fill this space with the hemostatic agents like Spongeston and Surgicel. And then we will place a drain and cover the kidney with repositioning of the gut. So post-operatively, the patient's blood pressure was completely controlled. He fared really well. He spent a night in the ICU and was shifted on the second day to the general ward, and was discharged on the 4th post-op day when everything was okay, and his blood glucose levels were even controlled, not requiring any kind of treatment. So the histopathology is awaited, although so I will share that as well on the channel. So we place a drain in the retroperitoneal space. It's a normal drain. We place it in the retroperitoneal space. Hemostasis has been checked by bringing the pressure down to 6, and there was no bleeding. So we replace and reclaim the gut histology. So this is the mass that has been removed, and this is the patient's specimen retrieval and port placement. Thank you very much for watching.